Hello, everyone. I'm Dr. Richard Berwick, and I'm here with my esteemed colleague and co-host, Dr. Camille Clare. We'll be hosting this Q&A session today on behalf of the Social Media Committee for Obstetrics and Gynecology, the Green Journal. I would like to welcome our invited guests today, Dr. Audra Meadows and Dr. Kemi Dole. So our discussion today is designed to really bring further attention to the recent special issue on racism in reproductive health, which was published in Obstetrics and Gynecology just this month in October of 2023. So there were many wonderful, important articles in this special issue, and we really want to recognize and thank all of the authors for their contribution to this important topic. Today, we'll highlight two specific articles, which were published by Dr. Meadows and Dr. Dole and their colleagues. And we want to thank them both for joining us today and for their outstanding work and advocacy in this area. So Dr. Meadows, first we would like to discuss your narrative review, which was titled Strategies to Promote Maternal Health Equity and the Role of Perinatal Quality Collaboratives. And Dr. Meadows, would you kindly introduce yourself to our audience and highlight your current position and some of your background work in this area?
Sure. Thank you for having me. I'm Audra Meadows. I'm a professor of obstetrics, gynecology, and reproductive sciences here at the University of California in San Diego. I'm also vice chair for culture and justice in our department. And as an OBGYN, I see myself as a birth optimizer. I have been providing care, championing health equity, and working to improve health systems for nearly 20 years. One fun fact is that I'm one of the founding directors of the Massachusetts Perinatal Quality Collaborative, also known as PenQuIN, which stands for the Perinatal Neonatal Quality Improvement Network of Massachusetts. It's a life course organization that focuses in on QI. Currently, I'm leading the implementation of our PenQuIN Maternal Equity Bundle across hospitals in Massachusetts. In addition to clinical research and administrative roles, I'm also happy to say that I direct a course in health equity and health system science here for the UCSD medical students.
Wonderful. That's amazing. And thank you again for all that you do there. So getting into your article on this narrative review, you speak a lot about the perinatal quality collaboratives. Just for those that maybe aren't as familiar with these, and explaining to the listeners, why are these collaboratives so well suited, in particular for addressing maternal health equity?
Certainly. Perinatal quality collaboratives are state-based networks of stakeholders working together to improve maternal and infant outcomes. Now, specifically PQCs, as they are called for short, they take action-oriented approaches to address maternal health, severe maternal morbidity, inequities, all through perinatal QI, and aiming to modify clinical systems and care processes. So it's important to understand that there are broad partnerships that we have to support these collaboratives and take action. And those partnerships include, and I'm going to list a number of them because it's really important to understand how broad that is. Those are hospital teams, the clinicians and their leadership, health departments, public health professionals, state hospital associations, risk management organizations, health insurers, community organizations, birth supporters, birthing individuals themselves, maternal health advocates, patients with their lived experience and their families. And all the work we do together is to improve outcomes. And currently, there are active or emerging perinatal quality collaboratives in all 50 states, including Washington, D.C.
And you mentioned, all those different stakeholders that are involved in the perinatal collaboratives. And, in particular, you mentioned groups such as patients and families and community organizations. Why are, those particular groups so important?
Yeah, I'd say patient-centeredness is a central tenet of quality. So when we think of the 6 domains of quality as defined by the Institute of Medicine, included within those are safety and equity, but also patient-centeredness. So involving patients and their families really ensures that healthcare decisions and interventions are aligned with their needs, preferences, and values. And taking a patient-centered approach leads to better experiences and better outcomes.
And what is you mentioned in the article, one thing that's been done to expand on these collaboratives on a larger scale is this National Partnership for Maternal Safety and the Alliance for Innovation on Maternal Health. Can you explain a little bit about what that is?
Yeah, those are two very important initiatives in the US focused on improving maternal safety. So, interestingly, the years ago in the early 2010s, a group of leaders of the professional organizations and advocacy organizations focused on maternal health, when we were seeing those numbers rise of maternal morbidity and mortality, got together and created the National Partnership for Maternal Safety. They really recognized a need for a call to action and urgency to address these matters. And that was as early as 2012. And so they began creating these creating priority safety bundles to address what are the common and most preventable causes of maternal morbidity and mortality at the time. And the approach that was taken was to have a structured approach for implementing warning signs, case review at your hospital systems, and then support tools and resources to address these issues. And so those first three bundles included obstetric hemorrhage, hypertension, and thromboembolism. As time moved on, what became sort of I would call a parent organization of the AIM, or Alliance for Innovation on Maternal Health, the AIM initiative, which is funded by HRSA, came after the National Partnership for Maternal Safety, and now is actually the housing organization of those maternal safety bundles. And so AIM was established to support perinatal quality collaborative formation and the activities to implement bundles, to maintain the safety bundle resources, which is really an important portion of that. So there's an annual meeting that AIM hosts. AIM has a website. AIM has a number of faculty and staff that go to the states and meet with the AIM, I would call AIM state leads within each state, to talk about the partnerships and to talk about what's happening with AIM and to talk about the current safety bundles. And also helping to provide a centralized data system for participation and sustaining engagement. What's important is that a lot of PQCs also have their own data systems, but when you register to become an AIM state with the AIM program, there's also a centralized data system with AIM as well. AIM has a number of safety bundles that are in place. Many of them, again, are focused on the leading causes of maternal morbidity and mortality, but they come with a very specific framework: readiness, recognition, response, also leading into looking at respectful and equitable care. So each of the bundles has a very structured layout, with taking a very structured approach to addressing maternal morbidity and including health inequities.
You cited, one important aspect of these collaboratives and quality initiatives is obviously to improve outcomes. And I think it was very fascinating in the review that you mentioned a few quality initiatives in particular that have been shown to actually, their implementation reduced racial disparities in severe maternal morbidity. And obstetric hemorrhage was one example that you gave. And I think that was one area where it actually decreased disparities. So, you touched on it a little bit, but how do the QI initiatives work specifically to improve maternal equity, particularly in regards to obstetric outcomes?
Yeah, it was really fun to do this narrative review for the fact that we could actually start to highlight some of these programs that I don't think many of us in our field were talking about. It was really fantastic when we saw the publication come from the California PQC that looked at a state approach, 99 hospitals involved, that implemented an obstetric hemorrhage bundle. And what they not only found was a reduction in severe maternal morbidity, those complications related to hemorrhage, but also showed a decrease in the gap between Black and white outcomes, to where there actually was no gap. There with the racial difference was closed, because the difference that was there, I think, was down to 1.02, and it was not even statistically significant. So it was really important to see that. It was important to see the work that was happening in Texas with Dr. Christina Davidson and her team leading quality work there. They were a hospital system part of the state of Texas implementing the obstetric hemorrhage bundle across the state. And when they were able to see reductions in their not only SMM rates, but also closing of that gap between Black and white patients, that was really huge. And then we saw similar information coming from University of Pennsylvania. And when we looked at other articles as well across the literature, we were able to identify what tended to be 6 key strategies. And those strategies to address maternal equity through a quality lens included looking at communicating equity as a priority through leadership. So that was the first. The second involved data, leveraging data to collect, stratify, and monitor or enhance surveillance of what's happening on L&Ds. engaging strategic partnerships, which was really key, and it's very key for your PQCs to have your partners working together and collaborating, engaging the community, which is a highlighted partner, and then educating clinicians, because we're still in the space of needing to educate each other and to continue to further our field and what we understand and know about health inequities. And then the last was implementing practice recommendations through collaboration, because that was really helpful to really start to drop the walls of the silos that we're all in within our healthcare and hospital systems, and work together and share ideas of how to implement quantitative blood loss for the obstetric hemorrhage bundle. Those were really important, and having those conversations was key, but also having the conversation about what led to health inequities, what are some of those continuing and ongoing issues related to bias that really create these differences, also is important in this endeavor.
That's great. And I really wanted to highlight, yeah, I thought that was a key feature that you highlighted, those six sort of equity promoting QI strategies. And I know you touch on them and you go into more detail in the review. So if we don't get to all of them in more detail, I definitely encourage all our listeners to open up this month issue of the Green Journal and read about those in more detail. I also like the strategies versus tactics, the strategies of the big picture sort of approach, and then the tactics about what is the action plan. At least that was my interpretation of, okay, now how do we take action and more specifics for moving forward? So it's really great. And I know you touched a little bit on each of these six, and I agree they're all equally important to the overall mission. I want to focus on leaderships, and we do often look a lot to our leaders to guide the rest of us, say in the academic area and in the community. So why is it so important that leaders make this health equity such a priority topic?
Yeah, I think the leadership is the most important, actually. It is the first and most important step. It's also a pillar of, for instance, IHI, Institute for Healthcare Improvements framework for achieving health equity. Setting and communicating a clear goal for equity is really key. And I'll say a little bit more about my experiences over the years. When I came into medicine, we were talking about what are disparities. We didn't use the word equity, and that was in the late 90s going into the early 2000s. We knew there were differences based on social and demographic identifiers. And the most egregious and the largest gap often was between racial groups. And we would hear that and we'd say race, was this risk factor. Well, we know now, and we can say it better now. It's not the race that's the race that's the risk factor, it's racism. And when we think about the fact that we've been talking about disparities for well over 20, 30 years before we're really starting to dive into what to do about it, it really shows the importance of leadership, that is the first step. Oftentimes, and many of us that are listening, I can say many of us at our hospital systems and within our healthcare institutions or medical schools have possibly put forward an initiative. And when you do an initiative and it doesn't have support from leadership, you may get a few things done, but sustainability, elevation of the work is really a challenge. And I'm not saying that that's not important to be able to step out, because leadership can find itself at many different levels. But with that being said, when you have the leadership of an organization stating that equity is a priority, making sure that everyone understands the conversation and the definitions and the words, what are disparities, what are inequities? Inequities are when there is a disparity based in an injustice. And there's something that we can do about it, and we can make that different. If we can have our leadership saying that, then now everybody is starting to pay attention. And when everyone starts to pay attention, people ask the next obvious questions. Where's our governance? Do we have committees to talk about this? How are we being held accountable? Where are those resources to support us to make action steps? Do we have a very specific goal? When you have those goals like healthcare systems that'll say, we want 0 maternal deaths, that's really important. When you have a healthcare system like University of Pennsylvania, where the leader there said, I want to see this disparity in maternal health equity close, or maternal health close, that was really important. It gave the resources and the instruction and the marching orders, I should say, for everyone to look at the issue and to get involved in making sure that a solution came about. That's really important. That's how we're going to get there. If we don't have leadership stating that this is important, that it's a part of our strategic priorities, that it's part of our budget, that's part of our governance, then we're going to keep seeing these differences and we'll keep talking about them. And that's not where we want to be.
Very, very well said. I agree 100%. And I think I'm so glad that you emphasized that point, and some great examples there of success stories as well that we see. And what about though, not all of us maybe are in leadership positions, or those who are in their institutions, maybe early in their career, that want to get involved in this area, maybe want to design their own initiatives, but they don't have the formal role or title. Uh, what should they do if maybe if they're getting resistance, or what are certain tactics or ways that they could do more to pursue work at their institution?
Well, I'll say I'm a true lover of QI, and you'll know why I say that when I answer this question, because I would say, leadership is not solely defined by titles or positions. Leadership can also be demonstrated through actions, advocacy, commitment to positive change otherwise. But I think that the steps within QI are very well suited. I encourage people to be intentional and to set a goal. If you set a smart aim, a smart goal, even for your career, for your initiative, for the work that you want to see happen, if you put those QI principles forward and set those specific goals, collaborate with allies, identify your allies, then those are some really great first steps. Interestingly, you have to also remember that birth equity is a journey. And I say interestingly because we named our AIM initiative for the Penquin Maternal Equity Bundle. We called it the Birth Equity Journey because we knew that this was a journey. There's not one thing that we're going to be able to do to solve all these challenges. Also, the work that we're doing within QI, within our hospital systems, is just one space. There are other spaces where work needs to be done if we're really going to solve this issue and truly reach sustained maternal health equity. But with that said, it's a journey. And so with any journey, great journeys start with just one step, just like big bridges can be built with small bricks. So I think one important thing, in addition to being intentional, in addition to making sure you have a goal, identifying your allies and partnering, collaborating with those allies, is also just give yourself grace and make sure you take those small steps, move forward, and just create your wins. Sometimes everything's not going to be successful, but when it is, that's fantastic. When it's not, you do a PDSA cycle. You look at it, you do a plan, do, study, act, and you move and you keep going in that direction of what are some of those change concepts that's going to get us there. But we have to do it together, because there are, times when people really want to be productive and do things in solo. But if we want to go, what is the old proverb says, the African proverb, if we want to go fast, we go alone. But if we want to go far, we go together. And so we really want to go far with maternal health equity.
Great. I'm going to have to watch this recording later so I can take notes of all these wonderful points and advice that you gave. I think this is really helpful for everyone. And I want to get, I think, a second point out of your 6 strategies was data. And I think we're all kind of seeing a lot about gathering data and leveraging data and how we can use it, and hopefully use it for good and to improve health equity. So some positions that I hear in practice, they're worried about the rise of quality metrics or data monitoring. They feel like that they're being monitored too heavily, maybe. But can you explain why data collection is actually and surveillance is helpful? And I know we touched on the OB hemorrhage, but why data collection and monitoring actually reduces disparities?
Yeah, I think the data piece is also, leadership isn't, I say, first step and most important, but the data piece is where it stands. We know about what happened in California and in Texas and Pennsylvania because of the data, because of what the story the data tells. Data stratification, collecting, stratifying by demographic identifiers, and monitoring what's happening in all of our clinical processes. So data stratification, surveillance, that should just be standard. That wasn't standard when I was training in residency. It's becoming more standard now. And yes, we do know that workloads are heavy, and we want to make sure that there are 2 important things that we think about for this maternal health crisis, is that we want to be efficient, because that is a part of quality as well. And so we want to make sure that our workforce is available and has the time to make sure that everything is going in the direction we want it to go in. What I'll say to that, though, is our country has worse and worsening outcomes. We're in a maternal health crisis, and the problem is not individual. The problem is related to systems. So if the problem is related to systems and we want to prevent morbidity, we've got to start to edit the systems. And that means we've got to look at our data. We've got to measure, because if we don't measure, what gets measured is what gets done. If we don't measure, we don't see it. We also want to make sure that data collection allows the healthcare systems not only identify disparities, but also the magnitude of disparities. We know there, again, have been years of research where we've identified disparities, but it's time for systems to collect, disaggregate, and monitor with real or race, ethnicity, and language, with SOGI, sexual orientation and gender identity, with social determinants of health, and with geography. When we're able to do that, then we're able to start getting at what are some of the reasons why there are gaps in outcomes, because no longer should the healthcare system provide care that works well for quote unquote the population. The healthcare system and healthcare should work for all populations, but we won't know that if we don't look at each population through disaggregation of our data. So to your point of overuse of metrics in healthcare, we know that is a challenge. And I actually don't have the answer to how to solve that challenge, except for the fact that we need to understand what are the types of measures that we should put in place that really get at disparities, and then start to collect data and surveil. And that is a powerful tool, we think, in reducing health disparities.
Wonderful. And then actually segues into the next question that I was going to ask you about, which measures and what are the right things to measure. And there's the figure in your review, which I think was really nice, talk about disparity sensitive measures. And it was kind of the central figure there, and it kind of pointed out other things around that, what defines disparity sensitive measures. So can you tell me what does that term mean, and what are the factors involved, and why is that so important, that if when we're doing these studies, to take that into consideration to actually move forward on improving health equity?
Yeah, this was an initiative and a report by the National Quality Forum. And so it was actually specific, not specific to maternal health, but looking at measures across healthcare. And there was a large group in a conference where over an amount of time, leaders got together and put together this identification or criteria, I should say, for what are disparity sensitive measures. And those are measures where when you measure something that is prevalent among a minoritized group or population, that it addresses a gap in quality of care, that solution and resolution is something that would positively impact the whole community in addition to the minoritized community. And it's something that maps to a communication sensitive or social determinant dependent practice of care that has a high degree of provider discretion. And so what would we mean by that? So I think of some of the process measures that we look at. So using obstetric hemorrhage as an example. And so within the obstetric hemorrhage bundle, there are the structure measures. So in the Donabedian model of quality, there's the structure, the process, and the outcome measures. The outcome measures that we're always talking about here are SMM, or severe maternal morbidity, a bit more upstream from mortality or death. And we're looking at that, and we're thinking about the structures that are in place that allow for processes to be optimized and ideal for healthcare settings. When we look at these measures for processes, we also want to understand that the processes that we have in place are leading to the outcomes we want. If those measures are disparity sensitive, then we can really start to make a difference. And I think an example of a disparity sensitive measure is QBL, monitoring blood loss through quantitative methods. The reason I say that is because we've seen now these other examples of healthcare systems that have been able to close the gap. We know that obstetric hemorrhage was prevalent among minoritized groups or Black populations, or Black birthing individuals. We knew that there was a gap in the quality of care, because when we use estimated blood loss, then that could create that gap. It also is something that leads to a high degree of provider discretion. We know the world over, and data the world over. There's data published from the 60s in multiple parts of the globe all the way to present, that we overestimate small blood volumes and we underestimate large blood volumes. So when we know that, if we can put in place something that we don't then have that gap that has that provider discretion, we can then start to really understand who is actually having an obstetric hemorrhage. And then we eliminate that denial of the diagnosis. So we actually make the diagnosis and we eliminate that delay. And that delay is the important piece. Timely care and obstetrics is really the difference. And so we have to be able to make the diagnosis and then get into the care. If we have a disparity sensitive measure, like whether or not quantitative blood loss is happening at a hospital system, that there are no gaps in the use of quantitative blood loss between the types of people receiving care at that institution, then we can start to see where those gaps can start to close.
Wonderful. That's a great example of the QBL, and just making data is data, and it's objective and it's impartial. And I think if we use objective data and make our management plans and do some of those safety bundles and algorithms based on objective data, you're right, it's a good example of how we could improve health equity and decrease those gaps. What about, collecting data that can be part of it in QBL, I think you're right, is a good example that hospitals implemented more routinely. But sometimes there may be some limitations or resource limitations, say in smaller systems, community hospitals, community clinics, and maybe there are individuals there that want to start gathering this data to improve outcomes in their own community. What advice do you have for hospitals that maybe have less resources, particularly when we think of the EMR and other systems that may be more complex?
Yeah, that's a challenging question, actually, because we know that that is a challenge within our healthcare systems is resources. And when you're in a resource rich environment, more can get done. A coordination becomes more the challenge. And when you're in a resource poor environment, you have to sometimes focus on those basic things that need to get done, especially in clinical care, like just providing the clinical care. So that's a tough one to answer, and I wouldn't begin to say that I have the answer to it. But what I think about is, since we've had EHRs, since we've had health information exchange units, we've been able to think about how people can access data differently. The fact that there's so much in this digital age, there's so much information that we can collect from those coming in to get care through just them using their own cell phones and giving information into the healthcare system, into our own EHRs. I think that's really helpful. I think we've got a long ways to go, though, to figure out that problem of what we can do for the resources for community organizations, for organizations that are solo. When you're part of a larger healthcare system, that problem is a bit solved by the fact that there may be entire departments within that healthcare system that are managing and monitoring data for the other groups, but that may not be the case. I will say, though, in the QI space, interestingly, some of the smaller hospitals just have a little bit more on the ground connection, and we actually are able to get more data submitted from some of the smaller hospitals than we have from some of the larger health systems. So even though I'm saying that in reverse of that concept, our experience in QI has been smaller hospitals have been really agile. And also looking at their data and knowing their populations really well, which is really important.
Those are great points. Thank you. Thank you for that. And I think we have a couple more minutes, and then I got through a lot of the questions that I wanted to ask you. And I wonder if you want to take a minute or two to just highlight maybe a current project or collaborative that you're working on, and maybe how it incorporated some of these things that you talked about today.
Yeah, I'll say a couple of things. I'm really honored to be invited to the narrative review. I'm very happy to work with the team that I worked with to put this review together and to have the privilege to highlight and showcase these wonderful programs and initiatives that are happening across the country. And these are just the ones that have been published. We know one of the other challenges is publishing quality improvement work in traditional medical publication fashion is not always the easiest. And so because of that, there may be lots more that I haven't even seen, but want to highlight and honor that those initiatives and programs might be happening. We are rounding out and wrapping up our maternal equity bundle in Massachusetts. And so I'm really hoping that we see the same data right now. Just preliminarily, we're starting to see a decline also in SMM. So we're hoping that we'll see a decline and a reduction in that gap in our Black-white gap in health equity and maternal health outcomes. All that said, what I'd also like to highlight is having the governance and having that leadership to support maternal health equity and health equity across the board in OBGYN is really key. Here at UCSD, we have a Culture and Justice Quorum, and hence the name of my title, Vice Chair of Culture and Justice. So we actually are the organized group of folks who put action forward to address all of those structures that we want to dismantle within academic medicine, so that as we're moving forward, we actually can have the not only processes and experiences and outcomes that we're looking for, but also have a system in place where that's sustained. And so I'm really excited about that. We also wrote up our Culture and Justice Quorum, and that was published in Academic Medicine last year. And so I think that we'll start to look at the successes and progress of having those kinds of committees. I think that we've started to see health equity focused committees happening all over the country in OBGYN departments. And now looking at, where we can be most productive and where we can be most successful, and really sharing that information across the country is also helpful as well. So looking forward to having some information to share there.
Wonderful, and we all look forward to seeing that when it's published and all that you do. So I want to thank you, Dr. Meadows, for your time and all your efforts that you're doing with you and the rest of your team. And I think you've inspired many of us, not just those here today on the call, but all of our listeners in the OBGYN field, and hopefully inspired us and given us the tools to really take this and these QI efforts and collaboratives into our own communities.
Thank you. Thank you. And I'm really impressed with obstetrics and gynecology for having the courage and foresight and vision to have a special edition on racism and reproductive health.